back shortly.
The topic is on medial tibial stress, but really this carries over to all bony stress related things. There's not much difference in terms of pathophysiology and etiology for like a femoral neck stress fracture. It's obviously a different presentation, but the injury pathophysiology is pretty much the same. So we'll go through that first. For the practitioner side, we'll go through a little bit of the rehab stuff or a little bit of the assessment-based stuff. And then we'll just talk through some of the rehabs that we start to do. It's not going to be super specific to probably MTSS because it's not MTSS because it's not specific really. Like it's all the same if it's a stress-related injury. So you'll understand as I get through to it. So the first part we're going to go through is the pathophysiology. So this is really important because especially us as practitioners, when we're very rehab dominant in sport, we tend to want to go, what can we do? How do we implement rehab? How do we implement treatment straight away? But understanding the continuum and the spectrum of stress-related injuries is really important because it's going to determine how fast you can progress through things. So stress injuries, again, like I said, are a spectrum starting from stress response all the way through to a stress fracture. Knowing where we sit along that is really important. So early diagnosis is super, super important. Basically starts, if we're talking about shin splints as an inflammatory response in the periosteum in the bone, and then obviously can end with a complete stress fracture. There's a couple of different things. So people think that tibial stress syndrome is very clear cut in terms of the mechanism. Everyone thinks it's just purely a loading thing. Obviously that's a high component of it, but there's a lot of other things and components that are part of it that are not as well researched, and we don't actually have a very clear, definitive, this is how stress injuries occur. So other things I've put in here, so obviously it's increased tibial strain through the actual bone, but other things including tendinopathy, periosteal remodeling is something I'm going to go through a little bit more in depth because I think understanding how this process works and how this can affect people, particularly when we're talking about distance runners, we're talking about people who compete in endurance events, and understanding that model and how that can be affected by things like diet and hormones, other stress, etc. Again, multiple proposed mechanisms, including chronic repetitive loading through the tibia, inducing bending at the site of maximal load. Other things that probably don't get talked about as much are high force contractions of deep neck flexors, increased stress on the tibial fascia. Again, things like this which are not super, super researched and they don't have a huge amount of evidence to support. But as we start to break down, as we start to do our analysis of someone or an assessment, we have to have a look at these things. Essentially what it comes down to is an accumulation of bone fatigue resulting in functional and structural integrity loss in the bone. It does not occur from a single traumatic event, so you're never going to get a stress fracture from a fall or from a tackle or anything, right? Obviously that's a high force trauma fracture. Stress fracture has to occur from accumulation of submaximal loading. The bony remodeling process. So is anyone caught up on their bone anatomy? Does anyone know the different parts of the bone? So the periosteum being the outer layer, the subcortical bone, trabecular, and the bone marrow. Right, so when we're talking about stress-related injuries, we're always starting on the outer layer. So through the periosteum. Similar to most other tissue, the bone goes through this process of tissue damage and remodeling, right? So it's actually an active, alive tissue, the bone. So we have bone micro damage. This is stress, right? So we're talking about micro, we're not talking about any sort of macro trauma, right? So there's micro damage to the tissue. The osteocytes within the bone pick that up. And then the osteoclasts come through and they actually clear bone, right? So the osteoclasts are coming down, they're breaking down that bone tissue. And it reabsorbs that tissue, and then we get osteoblastic formation, forming new tissue. In a perfect scenario, we're going to go through this process, and the remodeling process is going to be as much osteoblastic as osteoclastic happening. What tends to happen though when we have high force repetitive strain is that we have more breakdown of the bone, right? So When we have the bone remodeling process, during that process, we have decreased stiffness and elasticity through the bone, and new bone formation tends to be more porous, which means it is less strong. So it's a site of weakness within the bone. And obviously when we're talking about some of our athletes or some of our people who are running 150 to 200 Ks a week, or there's a high amount of increased load very quickly, and that process is not moving fast enough where we're laying down your bone, we're going to have a weakened site within the bone. And so it's going to keep breaking down through that spot. Here's the contributing factors that we always look at. So obviously the main one that everyone knows about is training loads. Rapid increase of training volume, rapid increase of training intensity, and frequency, all really, really important. We tend to find that when you ask people the questions and when you're going through a history, there's always some sort of rapid increase on what their normal is. So does anyone know what the acute to chronic load ratio is? You should know this. Yeah. You guys know what the acute to chronic load ratio is? So acute to chronic load ratio is a number that they've figured out where we look at a person's training schedule, we look at their chronic load. Typically we'll look at a 4-week block and say running, for example, right? They do a lot of this in the AFL. They do a lot of tracking. So they've got GPS tracking for their running throughout the week. And they'll say over a 4-week period per week, here's your chronic average load. Say it's 100 Ks of running. Then in a 1-week period following that, we can't have a drop, and the acute to chronic ratio can't drop. I think it's around 3 to 1. So we can't drop a massive amount and then try to reintroduce that fast. If the acute to chronic ratio is too large, we run the risk of having a soft tissue or a musculoskeletal injury. So this is really important when you're working with distance athletes because their chronic volume is super high, right? We've got a runner in the city who ran 217 Ks last week, and he's got to start to ramp down for city to surf, but he can't go and run 50 Ks this week and then try to kick it back after city to surf to 200. If he does that, he's going to get injured. So that's really the main thing. When we're going through our history, that's the first thing. What is your training volume? What is your training loads like? Has there been a spike? Has there been a drop? Did you get COVID and you didn't run for a whole week, then you came back and tried to run 50 Ks again? Most likely, you'll find that pretty quickly. Changes in training environment, so shoes, heels, the surface. So here we're talking about ground reactive forces. So obviously when we're talking about stress-related injuries, we're talking about ability to decelerate, absorb load. And if it's inefficient through that kinematic chain, we're going to have some issues. So if someone is a track athlete and they've started back running and they're running on grass, and then all of a sudden they hit the tartan or they hit the mondo again, and they're doing their whole week training on that, again, we start to look at these things. Bone mineral density is really important. We'll touch on more on that when we start talking about female athlete. Nutrition, so relative energy deficiency syndrome. So basically, essentially what that on a dumbed down version comes down to is what's my caloric intake. If my caloric intake is super low and I'm not sufficiently fueling myself to train, I'm going to have some sort of energy deficiency. That obviously then can go on if it's long term with a lot of hormonal effects. So we're going to touch on one of our runners, Ed, who had pretty much all of this going on. Biomechanics and strength is sort of our wheelhouse as practitioners, right? So we'll break this down more on what we're looking for when we're assessing it, what we're looking for when we're trying to return to play, and sort of the kinematic breakdown that we'll look at, and some things that we'll tend to find a lot of the time. And then the other main one is a female. Being a female obviously increases your risk. The factors there: bone width, muscle strength, the hormonal changes. I didn't go into the research fully for this presentation on training around period cycles, but I know that there's a fair bit coming out, particularly in like the AFL and the soccer at the moment, on how that's going to affect stress-related injuries and soft tissue-related injuries. But I cannot stress this enough. If you have a female athlete or a female who participates in a high repetitive sport like this and they get shin pain, you send them for an MRI straight away, because 1.5 to 3.5 times higher risk of progressing to a fracture. stress-related injuries, early intervention is so important. It really changes your whole prognosis. So I used to not want to send people for MRIs. If I've got one of our female athletes who comes in with shin pain, they're going straight for an MRI. And I'd probably say 8 out of 10 times they've had some sort of stress reaction. And if you get it early, before it's a fracture, it changes everything. So that's really, really important. All right, diagnosis. So clinical history is our first thing, like with everything. Vague diffuse pain along the middle distal tibia associated with exertion. So typically I start running, it's pretty sore. If it's an early stage, after I stop running and walk around, it tends to calm down. So it's exertional based pain. Again, what we went through, changes in training load, surfaces, etc. And obviously a female athlete, like I just touched on. So the female athlete triad, osteoporosis, amenorrhea, and eating disorders often go together very, very commonly with female athletes. So in saying that as well, particularly for distance athletes, sometimes this last one is pretty prevalent in our males as well. Right? If you're a distance runner, if you're a marathon runner or a triathlete, you want to be light. And most of them, I tend to find, this is anecdotally, but most of them tend to underfuel. So the physical examination, palpable tenderness through the medial tibia. Biomechanical assessment includes all lower body chain, right? So we're looking at knee abnormalities, if there's genivirus or valgum, if there's tibial torsion, femoral anteversion, if there's arch abnormalities, which I guess I'll get you guys to probably touch on a bit later, and how we would address that, whether we're looking at functional, whether we're looking at true foot collapse, leg length discrepancies, and then just your general screening, subtalar, ankle, knee, hip, right? Again, this is the same for any lower body injury we really get. But there's specific things that we're looking for, and I'll go through them in a sec. One thing I forgot to put in there, which I do touch on later, is obviously a gait analysis and our impact loading. So when we're obviously in a situation where we have the technology to test, using force plates to test things like landing mechanics, and doing a running assessment and a walking assessment on the force plates. So let's have a look. Let's see what our force profile looks like. Strength and motor testing, so super common. Triceps zero weakness, so calf weakness associated with this. It's something that probably doesn't get tested enough in clinic. So both pure isometric strength and then maximal strength within the calf, both bent knee and straight leg. So you two would notice that in the city we're doing a lot of calf isometric work at the moment, just to really bring that calf, that tricep strength up. Hamstring to quad strength ratio is something we also want to look at, particularly with runners, and landing mechanics. So put in there the Achilles stretch shortening cycle. Do you guys know what that is?
Stretch shortening cycle.
Yeah, do you understand what the stretch shortening cycle is?
Is that just the contraction of the Achilles?
Yeah, so it's a force loading through a tendon, right? And the Achilles is probably the most obvious one of this. So obviously when we're landing and we're talking about stored kinetic energy within the tendon, the stretch shortening cycle is that period where we absorb the load, harness it, and then we produce force.
Yeah. What about T-band? What is T-band with regards to...
T-band is very similar to the strength profile, right? So
inclusive with those strength?
it would for sure, yeah. So again, T-band is something that doesn't get tested very often, and strength of it doesn't get assessed very often, but it has a lot to do with that landing profile in the lower limbs. So general lower body strength, super important. And then gait analysis, like I said. So gait analysis is something that we've done a fair bit on, but I don't know if everybody has things that specifically that they look for. So obviously you can see what I've put there, but have you done much running based assessment? So on treadmill,
like... On treadmill, but I do a fair bit like rugby guys.
Yep.
That sprint stuff.
What do you look for? So say take sprinting out of it, just talk about running. What sort of things would you look for when you're trying to assess someone's gait?
Probably look at their foot strike first, at the heel, mid stance.
Yep.
Look at their pelvis, so that kind of anterior, posterior tilt.
Yep.
Look at their rib, upper body, what that's doing, and then from like a frontal plane, is there any kind of frontal plane movement,
Mhm.
pike, hip drop as they're running.
Yep.
So their foot collapse.
Yep.
Their pronation, supination.
Yeah, cool. Do you guys do a lot of running assessment?
Much running.
Do you do walking?
But
A lot of walking? Yeah.
I'd probably just add into that probably knee as well.
Yeah. So the only other things that you miss there, so if we cross the midline stance, so our midline position, and then we do a fair bit of work through mid stance, and again, it's just assessing how they, side to side and how they load. I didn't put any videos in here, but I think I've got some that we might go through. So diagnosis. This is a pretty good table I found. It's from a paper that I've referenced at the end. It's not exactly how I do it, but it runs through pretty structured. So for a lot of people, if you don't know, if you don't have a process, pain with activity, recent increase in training, we've got bone tenderness. They put here plain radiograph. I never send for an x-ray for this, particularly because early stage, it's not gonna show up. Like for the first 2 weeks, it's not gonna show up because there hasn't been enough bone mineral, there hasn't been enough happening in the bone to really show up on there, right? So a lot of the times where I had an x-ray and it's clear, for stress-related injuries, I don't even really would send for it. It's gonna show up if there's a stress fracture, but if there's a stress response, you won't see anything on it. There won't even be much soft tissue edema happening at the time yet. So if it's super early stages, I wouldn't even bother sending for the x-ray. So if it's a negative on there and we need an urgent diagnosis, then we'd go clinical suspicion straight through to an MRI, right? If this is like, again, if they're just a random person and they just run and they're not competitive and they're just like, yep, I've got a little bit of pain, do I want to send them for an MRI? It's going to cost them a lot of money. Is it going to change much? Probably not. So we go, okay, let's just avoid stressing it for a couple of weeks until it settles down, and then we'll start to reintroduce it. So what we're going to do anyway if the MRI comes back positive with a stress response, but they're not under a timeline, right? They're like, yeah, I just started running. I want to run for fun. I want to do a 10K at some point. Okay, cool. Let's avoid any high impact loading. Let's just train other things until that settles down. And then we'll start to reload your running back in, but we'll do it a little bit more structured this time. Okay, so that's just for your weekend warriors. They're for people who obviously doesn't matter as much to. But for everyone else, we're going to go straight through the MRI. That's going to show up pretty quickly. And as soon as you get that, then you kind of will then structure in your rehab process. Consider referral to sports med. I wouldn't really, unless I suspected that there was other things going and we wanted to get a blood test. And I'll go through it as an example again. But if we recognize that there was a change in load, they increased it, there's high force, we get the MRI, there's a stress response on there, probably don't need to see the sports specialist at that point, unless it's just not responding. Differentials, compartment syndrome is a big one. So I had a recent runner from the UK who's working with us for the next 2 weeks. I fully thought he came in, I've been training overseas, back in the States at college, been having this shin pain. I had plantar fasciitis before that. I'm like, yeah, it's a stressy. Got the MRI, all clear. So his was more an exertional compartment syndrome. So muscular weakness on that side, and then the increase in load there just has caused this exertional, so it doesn't get up when walking, it's just exertional. So cool, we got the scan, he's back in training straight away. Musculoskeletal tib post soleus, typically perineal entrapments, infections, and thrombosis, much less likely, and obviously there's going to be other things involved here. If I suspect it's a DVT, then obviously we're having a look at things like travel and things like that, but they're all things to just consider, particularly when you get the MRI and it comes back negative. There has to be a reason for his pain, so we have to figure that out. Imaging I touched on before, X-rays, chronic or high-grade injury only, so if I suspect there's a fracture, then yes. But early stages can be false negative because they won't show up. Bone scans, good quality, but MRI is probably where we go straight. Easy to access here in Australia, and they're going to be pretty pretty good at determining the level of stress. So we're going to go through the grading in a second, but the MRI is really good at helping us grade the injury. All right, there's a bunch of different grading systems out there for bone stress. They're all relatively similar. Some of them are a bit more in detail. I like this one because it's pretty straightforward. So grade 1 is asymptomatic periosteal edema with no fracture line. This is just like your early stage inflammatory, proper like medial tibial stress syndrome, where there's no real damage. Obviously that then just grades and progresses. So symptomatic periosteal bone marrow edema with no fracture. So that's when you look at the MRI and you start to see the opacity on the MRI going into the marrow. It's not just on the surface of the bone. Then we can obviously progress further. There's the edema with a undisplaced fracture, and then we can have a cortical stress fracture, which is probably almost more a trauma fracture than it is a stress fracture. But I put that in there mainly because we saw this with Ed. So Ed, one of our runners, had a 3 centimeter stress fracture in his calcaneus, and it almost looked like it was about to break off. So it's still a stress fracture, but it was like, I think I've got the images. It was horrendous when you looked at the photos. So, and again, here's the different grades on MRI. So we start having a look at grade 0, healthy bone. Grade 1, we start to get that little bit of periosteal reaction. Into 2, we're starting to get a little bit more, and we start to get a little bit of inflammatory process coming down through the subcortical into the bone marrow, and then that just keeps progressing until we get a fracture. Okay, X-ray. Again, you can just see that little bumpy line coming through there. That's the reaction. It's obviously no fracture on that. All right, management. So the number one thing, and I guess the thing as practitioners, talking to athletes, talking to people who want to train, is the only known thing to help reduce this is complete rest. And it's like one of the only things you have to tell people, no, you just have to rest it. But that's contextual, right? So if they're a runner, they've got a stress fracture in their foot or in their shin, depending on how quickly we want to get it right, sometimes I'll put people on crutches. Sometimes people go in a boot. Right? Typically, we want to put people on crutches for that first 4, 5, 6 days. Do not load it at all. If you want it to settle, do not load it. So this is a pretty basic, and it's obviously not specific to any individual, but it's actually a pretty good way of looking at that loading mechanism. So crutches until no pain with walking. We test it every second day. Every day if it's a really low response. Phase 1, walking pain-free for 5 to 10 days. Phase 2, 30 to 50% of pre-injury total load on alternate days. Phase 3 is restore 10% of pre-injury exercise volume per week. Over 2 to 3 weeks, we go on a 2-to-1 work to rest ratio. And then phase 4 is full return to sport. These are time specific at the start, then they become less time specific. They become more objective based. Coffee. So, as practitioners, what does this mean for us? Jace, if you get someone comes in, you get the MRI, okay, there's a grade 2 stress response, what do you say to the person?
Modify the training load.
Modify the training load, in what way?
Reduce it on.
Reduce it or completely take it out?
Depends
On what?
on whether they are professional athlete. Or
So if you're a professional athlete, I'm putting you on crutches, 100%. This is where I'm like, there's no, as chiros, as physios, as practitioners, as rehab, we're like, no, we can get you right. You're not going to get that to heal faster with anything you do. They have to rest it, right? You modify the rest of their training, yes, but there is no loading.
You could say that with most bone reactions.
Any bone reaction, yeah. Bone is different than soft tissue, right? Soft tissue, if you do a grade 2 ankle, load it up, put it in a boot for 3-4 days, then load it. With bone, there's no leeway. Okay, basically, if you start back early and they feel pain, you're going back on crutches because we're not letting this progress. All right, we've got one of the girls in the city, Em, who, when I first started treating her years ago, had a bit of pain in her foot and she was seeing someone else. For 8 weeks, she was seeing a chiro and they were adjusting her foot for 8 weeks. And then I saw her for the first time and sent her for the MRI. And the way that you look at it is, if she was put in a boot at the start, she would have been in a boot for maybe 2-3 weeks. By the time I saw her, she probably would have been back running. Low force, maybe on Alter G. But now she had to go in the boot for 6 weeks because it was a full fracture, a navicular stress fracture. So, and I've seen it before, and we've probably done it before, where you try to bring someone back too early. Oh, no, we can just do some little bit of loading, and then it flares. And it's not necessarily going backwards, but you just keep perpetuating this cycle. So this is really important. I go through later the psychological stuff, particularly with athletes, but it's really important that you set up at the start. You have to rest this until it has no pain, because most of them will be like, oh, it feels pretty good when I'm on crutches, not loading it. So they'll go, I'm going to try to go for a run. All right, we've all seen it. So complete rest is the only thing at the time, early initial, that is non-negotiable. Context dependent means obviously the severity of the injury, the demands of the sport, and exercise modification, meaning if this is a really low grade, it's just a little bit of periostal inflammation, I don't need to rest for 5 weeks. I might rest them for a week. I might rest them for 5 days. Can you walk pain-free now for a few days? Yes. Cool. Now we can start some proprioceptive work. Now we can start some lower body loading, really low force. Obviously then the introduction back to impact loading takes more time. And that's where that starts to become more objective, right? We start to introduce things, how does the body respond? But initially, no loading until there's no pain. From a treatment side of things, evidence is really all over the place. There's not really a lot of high quality evidence to suggest there's anything that we can do to help assist that, because it's a bony process, right? It's a healing process. There's some evidence that physical therapy, including non-steroidal anti-inflammatories, hot cold, soft tissue work like needling, shockwave, can benefit, but most likely it's all secondary benefit. All right, if I've been on crutches for 2 weeks and there's going to be things that are tight and sore, there's going to be things that we can work on. So there is benefit for us in some ways to treat, but typically it's not going to be assisting that bone to heal faster. Do not progress until there is no pain with walking. If they're like, oh, I walked for 10 minutes and I had pain, well, you're definitely not running.